Good evening, everybody. We're going to be starting right now. Thank you so much for joining us tonight. And tonight's topic, I think, is going to be relevant for everybody here. Those who have some aligner experience, those who are new to aligners. I think everybody here has used us, right? Is already a customer? Is anybody who's not a customer? No? Okay, perfect. Just have to check. So tonight's topic, it's going to be relevant because setting up your correct aligner case, the right aligner case, especially for your first 10, 15 aligner cases is crucial. It's crucial because you're learning, right? You're still new to aligners. Even if you're not new to aligners in general, you're new to our system. So picking up the right aligner case, it's going to make the whole difference between you being frustrated and your patients being frustrated and you actually having success. So just really quick about me, so you know who I am. I am a general dentist. I actually did an AGD fellowship and an AGD residency. I actually completed a GPR residency too. I was faculty for the University of Connecticut, where I completed my fellowship and my residency also. And I went into the industry afterwards. The industry means that I left clinical practice and I was medical affairs senior scientist for Sensorinam Pronamo for approximately 3 years until I joined 3D Predict. And the reason why I joined 3D Predict, and I say this every time I speak, is because this is really, really the future of dentistry. This company is doing amazing things for patients, not only for doctors, because it's bringing the whole supporting structures of the mouth, right, of the teeth, into play where nobody else is doing that. So you all know that probably by now, but I always like to repeat it because I can't work for a company that I don't believe in. To me, patients are in the forefront of everything we do. Now, agenda for tonight, we're going to talk about defining your goals. And I know this may seem very basic to a lot of you, but let me just preface this by saying all the topics that I'm going to present tonight are coming from all the many medical calls that I have per month with doctors just like you, doctors who have experience with other aligner companies, doctors who had basically no experience with aligner companies, because it's easy to know things in theory, right? But when you're actually seeing the patient, a lot of things slip up until you're in a call with me or with a technician and you have that moment where you realize, wow, I didn't really focus on this at the beginning when it was there all the time. And you're gonna notice you're gonna know what I'm gonna say in a second. So we're gonna talk about defining your goals, clinical and financial, because we're in the business of dentistry. This is a business, it's finance too. We're gonna talk about ideal starter aligner cases. Should you take a CBCT or no CBCT? We get this question all the time. I want you to leave tonight clear. When do you need a CBCT or not? And if it's not clear, please ask me, because I want you to have reassurance when you're submitting your cases. And we're going to show you some cases, examples of cases that are great to start with, right? So let's talk about defining your clinical goals. So we're going to go through, what is the patient chief complaint? And what are your goals with this patient? You know, I had a call, I think it was like a week and a half ago with a doctor. And we got to the point that the doctor, because she was moving posterior teeth, right? We have all this treatment plan set up, that it was outside of predictability limits, and the doctor was frustrated. She hadn't even approved the first treatment plan, by the way. And I actually stopped the call and I said, but doctor, what is the patient main goal? What is the patient chief complaint? And that was not on the prescription. And she said, oh, it's actually number 7. Number 7 is pushed back. So when the patient smiles, her grandkids tell her, Grandma, you have a crooked tooth. And the patient was just upset about it, right? And I said, well, we're moving posterior teeth. What are we doing moving posterior teeth? We should be focusing on social 6, right? Canine to canine. So let's align those social 6 teeth. And then your patient is going to be happy. What are we doing correcting class here? And we're going to talk about that too in a second. And that changed the complete outlook of the treatment. It brought trace down the length of the treatment, right? Because as dentists, we sometimes focus, right? Perfection. It has to be perfect. But does it really have to be perfect? It has to be perfect, obviously, from a functional point of view, right? But when we're talking about aesthetics, it has to be where your patient is happy. And we need to learn how to set those boundaries and those goals. Now, treatment expectations. Are your expectations realistic? You know, one of our high executives like to say, and Marina will know who I'm talking about. Marina's our CEO. We're not magical. We are not made of magic. Everything we do is scientific. It's based on biomechanics, right? Physics, right? So they are treatment limits to everything you do, whether they are limitations based on what aligners can do in general, based on what 3D printed can do, or they're anatomical limitations, and we're gonna talk about that. And case complexity. So this is a little bit what I was saying, right? What are your main goals? What is your patient chief complaint? You see this patient is class 2, right? This is a class 2 patient. We are getting to class 1. Distalization that is happening here is a hard movement to accomplish. Can 3D printing accomplish it? Yes. Actually, for class correction, it has been proven, you know, by research, ortho research, that you usually need 1.5 millimeters of distalization for class correction. 3D printing gives you 3. So you're not gonna have to use rubber bands or anything like that. But this movement is gonna take longer than if you were not doing it, right? So you need to have that in mind when you're discussing class correction with your patient. You can't promise your patient this treatment is gonna take 6 months. So now, if this class 2, and I'm using class 2 as an example, but you can extrapolate this to almost any type of case, if this patient shows up, right, is happy with their profile, is stable, so there's occlusion stability, the patient is functional, there's no wear facets, why are we correcting class? You know, in dental school, and orthos will tell you, orthos don't always, orthodontists don't always correct class. In fact, a lot of the times they don't, because they know the patient is stable where they are. Now, if you have a huge overjet and you need to correct it, then you can think about doing the distalization, right? But if the patient is happy where they are, then this maybe is not needed. You see, this is another class 2 patient. Are we correcting class here? No. We are just correcting crowding, because this was the patient chief complaint that should be aligned with your goals. Now, if you need to have a functional conversation with your patient, that's a different situation. But as long as the patient is stable where they are, right, you can align your goals to the patient chief complaint. And that's gonna make a whole world of difference on how you see your cases. So I got these pictures from a journal, you know, and this is interesting, right? You see this patient, right? Some crowding, some crossbite, anterior crossbite on this lateral here. This is a very nice result, right? After expanding, you know, doing some alignments, some rotations of laterals, right? Very happy with this result. Until you look at this. You see this blanching of the tissue right there? That's root eminence. You're seeing the root through the gingiva. There's no bone here. No bone, no bone. And the reason why you are not seeing gingival recession is because this treatment was completed within 5 to 10 years. After 5 to 10 years, you're gonna start seeing gingival recession because the gingiva follows the bone. We all know that. And then this patient is gonna have some peri implications. Maybe he's gonna need periosurgery. You know, I wanna bring it to you. Talk to your periodontist, the periodontist that you trust, that you refer to, and ask them about perio issues after ortho. You're not gonna see the end of that conversation, because every periodontist I have talked to have concerns about this. And the reason why I'm bringing this is, please keep in mind when you look at a patient, not all patients can anatomically support class 1 or any other occlusion ideals. So if you see this type of patient right here, right, I can assure you right now, because of the severe crowding, because of the severe crossbite, this patient, if you try to bring this patient into perfect overbite, overjet, class 1, whatever it may be that we learn in school, right? Then this patient is going to be overexpanded, and you're going to have this type of situation at the end of treatment. This is a picture that I got from another journal. And you see here, there might be some recession, gingival recession on the canine, but just nothing too bad. You still see the tissue blanching, not as bad as I showed you before. But when they raised the flap, okay, they actually noticed there was a lot of dehiscence on this patient, because this is a product of extreme expansion, extreme proclination of those teeth. So when you are looking at your patient, you have a severe class 3 skeletal, severe crossbite. Don't think that you can reach perfect occlusion ideals, because it's just not realistic. And that's a good thing about 3D Predict, because we are gonna let you know if we have concerns about any prescription that you may send to us with this type of end goal in mind. And that brings us to case complexity, right? This is very useful when you have some ideas of what you may need in cases, right? I want to point out that our limits are bigger than other aligner limits, just because we take heavily into consideration the anatomical boundaries of your patients, and also biomechanics, center of resistance, where the apex is, et cetera, but you know, right, that you need, for example, to heavily rotate a canine. You can have an idea how much you're gonna rotate that canine. If you need 180 degrees of rotation because that canine is completely facing lingual, right? Obviously, that's gonna be outside of predictability limits. And if it's outside of predictability limits, it's gonna be a complex case. We're not talking about anatomical limits. Anatomical limits was before, but you need to keep both in mind when you're submitting cases. If you're planning to close a space after you do extraction, you can kind of know how much you need to close it. Can you achieve that with this amount of distalization, this amount of mesialization, or is it gonna be bigger than that? Then it's gonna be outside of predictability limits. Anything that is outside of predictability limits may need a refinement. You just need to be ready for that. If you have a call with B, if you have a question about a case, is this within predictability limits? Is this outside? Is this achievable? Is this not? I encourage you to reach out. We're here to provide answers for you. But obviously, when you look at a case like this is definitely gonna be outside of predictability limits. Now, would you wanna treat this case? I suggest not. Not because 3D Predict can't treat it. We can, within anatomical and predictability limits. If you want to go outside of this predictability limits that this case would definitely need to go outside of, then you're looking at 2, maybe more refinements, because this is a very complex case. And then the conversation with your patient changes, right? You need to prepare your patient, especially when you know they are complex, they need a lot of movement for refinements. We pride ourselves on no refinements, but those refinements are within our limits of predictability. Now, another thing to take into consideration, another picture from a journal, right? This case, you see, this is a periodontally stable patient. She had periodontitis at some point, right? But obviously she was left with a lot of gingival bone recession. And you know the bone recession is way more than what you see just looking at the gingiva. A lot of missing teeth. This is not a case that I suggest treating, at least for your first 15, 20 cases with us, or with any aligner company, to be honest with you, because the literature is clear. Can patients that have periodontitis, because periodontitis is chronic, it's never good, but they're stable, they're controlled, right? Can they undergo ortho treatment? Absolutely, they can undergo ortho treatment. The problem with that is that it turns into a surveillance situation. You need to keep that patient under a strict hygiene and visit control from you. because that periodontitis can reactivate at any point during treatment, and you need to be there to be able to catch it. So I highly suggest you don't start that, when you're just learning a new system, a new treatment, because you want to set yourself up for success. Also, the center of resistance changes, right? The biomechanics for moving teeth that are periodontally involved change. So this is a perfect case example, and we're gonna talk about that later, where I highly suggest you submit a CBCT. Because without knowing how much bone is actually covering this number 8, without knowing how long this number 8 is, it's impossible for us to actually determine the center of resistance. And this is crucial for this type of patients when they are so much periodontal involvement. Now, when you have a lot of missing teeth, and this patient has both, right, periodontal situation and also missing teeth are very hard to deal with when you're dealing with aligner treatment, just because we need to have anchorage. We need to have anchorage when we are moving teeth. And when you are missing a lot of posterior teeth, it's very hard to gain that anchorage. When you're missing a lot of teeth in general, it's hard to gain anchorage. We will let you know. You can submit this case by all means, but I would not make promises to the patient, because we will have to calculate if we have the anchorage we need to move the other teeth to get to the goal that you're trying to achieve. So if you want to submit this case because, hey, this is my sister and she only trusts me, right? And she won't go to anybody else and nobody else will treat her, please. Let's say this patient shows up and said, I just want, and by the way, this patient was treated with brackets, with this situation, with no perio involvement afterwards. And she looked great. I don't have the after pictures, but you can take a picture of this and look at the journal article, because it's available online. It's open access, but she just one ortho treatment, and the orthodontist said we can do it, and they did it. But my point is, not all patients are gonna want to do, what we tell them to do. We have to have options for the patient. And some patients come with a set mind and say, hey, I heard that you can align my teeth and make it look better, and maybe I can get away with this, right? Can they get away with it? Maybe. But I will not make promises, right? And obviously give them several options like you just said. Now, this is an example of a complex case. And this is a case that was submitted probably a year ago. And after we had a clinical call with the doctor decided not to proceed forward because she just didn't see the value of moving forward with this case. So you can see a lot of rotations, severe crowding upper and lower. And not only that, there was a lot of involvement of those lower anterior teeth. They look worse after the treatment because we have to procline them, right? The patient didn't want extractions. That's another problem, right? And so once again, you can't just give patients everything they want. We're not magicians. And this is just the PDF form. Whatever you see on the PDF form, and I suggest you always look at the PDF form in your cases, because whatever is in red is outside of predictability limits. So it's always good to have that reassurance that everything looks green. And if something looks red, you can always send a note back to your technician or set up a call with me and the technician, and we can go over this. But this case, because it was complex, because the patient didn't want extraction, because the doctor didn't even want to do IPR, right? Yeah, your face, I know. Then once again, we're not magical. Then this is what we could give the doctor. And we had to tell the doctor, is this achievable? Yes. Within predictable limits? No. Is it just gonna take 22 aligners like you said? Probably no, probably it's gonna take double. Is your patient willing to go to 3 years of more of treatment without burnout? That's a conversation that needs to happen. So the doctor at the end said, no, this is just too much for me. I don't wanna deal with it. And I don't wanna compromise on any of the other things that you just suggested, so let's just cancel the treatment. So just have in mind, it's always better to under-promise patients, right, than to overpromise and not be able to deliver. So that's a very important conversation to have at the beginning. So let's talk about your financial goals, because like I said, we're in the business of doing dentistry, right? So always try to shoot for 1 year or less. If you want to be really profitable with aligners, 1 year or less of treatment is ideal. 24 steps, 24 aligners or less is what's really going to be profitable for you. Now, we need to talk about complexity and refinement correlation, which I think it should be clear by now. The more complex the case, the more refinements you're going to have. You have to be willing to compromise on your profitability at that point, because our chair time is valuable. Time is money in dentistry and in any industry. Every time you see that patient, you're not charging them per visit. You charge them a lump sum per aligner case, right? And every time you see the patient, that revenue is going down per visit. So you need to keep in mind that it is a profitability game. And I want to point out too, because there are a lot of doctors that I have talked to throughout the years that have said, well, you know, I don't know if I should do more aligner cases, because I do crowns and I do implants and I know how much I'm making, or I think I know how much I'm making. But aligners is just so new. I don't know. Should I do it? Should I not do it? And I just want to put your mind at ease. It is profitable. And not only is profitable, it just makes sense clinically. And I'm going to bring that up to you in a second. But other doctors also, talking about the length of case, right? Because they said, well, you know, I want my case to be 1 year or shorter. I got that. I understand. And one more thing about the 1 year mark. After 1 year, your patient starts getting tired. They don't want to wear that aligner anymore. They are like 22 hours, I don't care. I'll wear it 16, right? And then the case stops tracking. And then you have refinements. And then the case becomes longer and your profitability goes out the window. So that's another reason why your case should be 1 year or shorter. But sometimes you want to submit a case, right? And it has happened to a lot of doctors too. They say, well, I want to charge my patient this. And to charge my patient this, I need to sell them a short case, right? Or a super short case, which is 8 aligners or less. And then they promise this patient that this is going to take 14 aligners. And the treatment plan comes back, right? And it's 20 aligners. And now we're at impasse with the patient. Because now you have to deliver the bad news to the patient that, oh, by the way, this can be done in 14, it's 20, and I'm going to have to charge you more. And sometimes who ends up eating that cost? You, right? Not the patient. So this is a very useful chart that is actually in your doctor's portal, and our sales rep can give it to you too, where you obviously, a lot of it is a guesstimation when you're looking at a patient, but some things are very clear. So are you correcting class? Is not a short case. I can tell you right now, if you are correcting class, it's not a short case. Are you aligning the midline? Is not a short case. It's a full case or a deep CBCT case. Are you treating open bite? Are you treating deep bite? Are you treating cross bite? It is a full case. So those type of things are useful to know when you're first looking at your patient, so you don't overpromise. But as a rule of thumb, I will tell you, please don't ever overpromise your patient. We have all done that, right, in clinical practice, and it has backfired at least once or twice. So it's better to underpromise and then bring the good news to the patient. Oh, by the way, I told you it was going to be 20, but it's actually 14. So now you have to pay less if that's what you want to do. Right? And like I said, you can find this in the manual section under your doctor's account. It's called Select Your 3D Printed Case. So it's good for you to have. Now, Chris Benson, who is a very renowned financial expert in the ortho world. He actually, has, the AAO has him very high esteem. They invite him to the AAO annual meeting every year just to talk about finances for orthodontists. Came up with these numbers, right, actually from a survey from Gage in 2022, so very recent, where they said all aligners in general have 12 visits, right? And that's with an orthodontist. So we can think that maybe for us it may be more, right? And in general have 2.5 refinements per case. The revenue per visit, then it turns out to be 431. You can extrapolate this to your own numbers. It's fine, but it works the same way. Now we have run these numbers in 3D Predict, and if you submit a good aligner case, right, moderate, and we're going to talk about that, moderate, mild crowding, etc., to begin with, for your 15 first cases at least, until you get used to our system and how aligners work, you should have less than 1 refinement per case. That brings the visits to a half, and that increases your revenue by 50%. It's just common math. It's just simple math. It just makes sense. So why would you want to have more visits with your patient if you can prevent your refinements? Because what brings the visits to a double is actually the refinement that you were not accounting for. And these are actually real numbers from one of our customers who's a general dentist just like you. He does a lot of implants and he does a lot of aligners too. And he has been in business for many, many years. I think it's 30 years or so. But this is what he makes for, as a net profit per visit for implant and crown, right? And this is what he makes net profit per visit with 3D Predict. So you can see these numbers are pretty similar. And when I show him this, right, because when I did a review of his cases, he said, well, you know what? This is actually not a fair comparison because I hate doing implants. It's so much mental load on me. And then, I have to do the surgery, and then the patient has a complaint, and they call me, and they need to come back, and they are in pain, or whatever it may be, right? Or they just want to be seen because they want reassurance. So, and every visit takes me at least 45 minutes. Whatever the visit they may be, it takes me 45 minutes. And he said, but doing aligners is different, right? It's non-invasive. Right? Sometimes if I don't have to do attachments, if I don't have to do IPR, I don't even have to see the patient, my assistant, because he has really well-trained staff, right? Because he does a lot of aligner cases that just give the patient the new sets of aligners, make sure they fit, and the patient is on their way. So that takes 15 minutes usually. So that's why he said it's really not a fair comparison. I would think it's even as profitable or even more profitable than implant and crown, right? But obviously there's not a set way to measure that right now. But this is what he is profiting per patient with our system, which is $5,016 per patient. And please always make sure to reach out to us because we're here to support you. But I just want to show you this number so you see it makes sense. But it doesn't only make sense from a financial point of view because everything is related, right? Everything is related, clinical and financial. And that's why I love dentistry, because what makes sense clinically, it should make sense financially, but in the 3D Predict case, it does. And that's a beautiful marriage. You see this patient, you see the bite, you see it. I know I saw it every week. You see those deep bite cases. What are you doing about it? What is your conversation with this patient? Are you having any conversation with the deep bite cases? Are you telling them that maybe in 20 years, if they're young now, let's assume, in 20 years, they're going to need crowns or the lower teeth? Or they're going to have their supporting structures needing some perio work? Because that's usually what happens. We should be treating deep bite cases. It's our responsibility as providers. If you don't want to treat them, you can always refer them. But now you have the option to treat them. Deep bite is hard to treat. It's difficult to treat because intrusion, which usually is combined with torque for anterior teeth, is two very difficult movements by themselves, but combined, they're even more difficult. Basically impossible without using rubber bands and all that. And we're not going to start using rubber bands. But with 3D Predict, you can now start treating these cases. Now, you can extrapolate this to anything. Do you need to make space for a crown or lower by intruding an upper molar? Do you need to make space for your implant? You can do 3D Predict. And talking about implants, right? You see this case. What is the conversation with your patient? I want an implant here. And the patient is just coming thinking, I'm going to get my implant and everything is going to be good, right? And that's it. And then you start talking, well, this second molar over here, right? What are we going to do with this? Because we don't have a space. So maybe you're going to need a maybe a crown, but maybe you're going to need a root canal. And who knows what else? And the patient starts looking at you like, what? No, but this tooth is healthy? Why are we touching this? And you have to go through your whole explanation. Yeah, because we need space and do. And it also doesn't feel good because, once again, we have been ingrained in dental school. It's healthy enamel. Why are we touching it? Why are we violating this tooth? And the only reason why we're doing it is because we're making space for the implant. Otherwise, we wouldn't be doing it. Now you can have a different conversation with your patient and say, look, in 4 months, we can open that space with aligners. And we don't have to touch his tooth. I encourage you to have the conversation of how you will normally do it, right, with crown and root canal, and tell your patient, which is what I usually told my patients, is go look in Google. Dr. Google sometimes is good to use for this type of thing. Use it as a weapon, and say, go to Dr. Google and see how I will make space for this implant. And they're going to confirm what you just told them, which is root canal, crown, et cetera, et cetera. Now, you have the option, because this was not an option before 3D Predict, to make that space by writing that second molar in only 4 months with no rubber bands, with no mini screws, mini implants, or anything like that. That is a nice change. Also, you get that tooth in a better anatomical position. Just for occlusion purposes, just to have root parallelism between this and your implant. It just makes sense. It really is better for your patient. One time, one of our speakers who is a prosthodontist says, dentists usually feel guilty about overselling patients, but you're not overselling the patient. You are offering a service that is needed. Is needed for them to have a long-lasting treatment, a successful treatment, not just something that is aesthetic. You see, this is the same prosthodontist that I was talking about. He looked at this case and he's like, yeah, this is a complex case. This patient doesn't have teeth bite, but she has a posterior collapse occlusion. How are we going to open this? There's really no more tooth structure to be preparing this for a crown. Now we need to start thinking about crown lengthening, right? Who knows what else? So this is difficult. A lot of you may try to do it. I would send it to a prosto and be like, I'm done with this. I don't want to deal with it. But with 3D Predict, in 5 months, you can get 2 millimeters of posterior intrusion and place your crowns. Do the patient a favor. Why are we going to start taking more precious bone around this tooth if it's not needed? You're doing the patient a service, and you need to let the patient see that. And 5 months is nothing. It really isn't compared to anything else. Same numbers from the same provider that I just talked about. He does a lot of aligners, and to us, a lot of aligners is 2 cases per month. You can see, just submitting 2 cases per month, he submits 20 cases per year. He's making $128K on just 2 cases per month. We told him if you submit 3 cases per month, you could be making 230. So you see patients that need aligners. I really, really encourage you to have the conversations and to have a sit down with yourself and think, how can I look at cases differently where aligners can do a service for me and the patient? It's not only about aesthetics. It should not be about aesthetics ever. It should be about function and restoring teeth to their proper position. So we talk a lot about red flags, right? What you should look at when the cases are not ideal, but what is the ideal starter aligner case? And when I talk about a starter aligner case, I mean the first 15 to 20 aligner cases. This is the ideal aligner case to start with. This is not what you need to be stuck with forever, but to start with, mild to moderate crowding are great starter aligner cases. You need to get used to our system. You need to learn something that you were not taught in dental school, right? So you're gonna learn about attachments, how we handle attachment protocol that other companies don't tell you about, because attachment protocol is crucial. I was just talking to Marina today about it. IPR, why it's so important, all that good stuff, when you should see the patient, how often you should see that patient, all that it's crucial to learn. And once again, what are you treating? What are you treating? This was actually an ortho case, an orthodontist case. The orthodontist wanted to correct class. They did distalization. When they look at the treaty plan, they saw this dehiscence and they say, oh, no, no, no. I don't like this. I don't like that it's 40 steps. It's just too long. The patient is not gonna like this almost 2-year treatment. How can we bring this down? And we actually suggested, well, doctor, you know, we could be doing, instead of distalization, we could be doing some expansion. Are you really wanting to correct class? And the doctor said, no, not really. And we said, well, if we expand it, and we knew the patient had the alveolar housing to do it, then the dehiscence just basically disappears. And then you can correct the crowding that way. And the treatment goes down by 13 steps. So this is why I said, what are you treating? Because if you're treating this case like this to me is a moderate crowding case. It's not a class 2 case. But this is a real class 2 case. It's basically the same patient, but the way you're treating it, it's a complete different approach, and we look at it differently. So CVCT or no CVCT, the question that I get at least 5 times, 5 days out of the 5 days of the week. CVCT. I know. Yeah, CVCT or no CVCT, right? Now, let me just say, 3D Predict is great. We have 2 bits of our AI, which is the CVCT analysis when you submit CVCT, and there's another bit, which is just the information that is coming from the database of the thousands of cases that we have treated, and we use those average, anatomical average, and predictability average, and you implement it into the cases that don't submit a CVCT. But I'm not gonna stand up here and tell you that CVCT is not king. I mean, if you have a complex case, submit a CVCT. Submit a CVCT, and we're gonna go through that. But if it's not really a complex case, you can get by without a CVCT. The beauty about 3D Predict is that we are a fully customer-oriented company. So if you don't submit a CVCT, right, for any reason, and we strongly feel you need a CVCT, we will reach out and we will tell you, doctor, this case really needs a CVCT. We're not gonna do it for every case because we really do it only when you actually need it. But if you submit us a class 3, we are gonna reach back and say, doctor, you should have a CVCT. If you decide not to submit it, it's completely up to you, and we will utilize our database of cases, but it's always best. And this is just an example, right? This was an ortho relapse case. This doesn't really look that much like much, right? If you go back to the previous video, there's really not much movement happening here. I mean, there's some, right, but not too much. When you look at the actual CVCT, right, deep CVCT analysis, you see that there's a lot of dehiscences happening. So things that may look simple may not be simple. But keep in mind, this is an ortho relapse case. Ortho relapse cases are a complete different beast on their own. Now, we all take a pen, we all take an FMX when we're gonna treat our patients. If you see this, unique root anatomy, unique root morphology, if you see that the patient has relapsed, the roots are very close to each other, if you know you're gonna be treating that patient and doing a lot of distalization and the sinus is right there, right? Please submit a CVCT. Root collision, anatomical collision with the sinus is real. Unique root anatomy needs to be addressed with CVCT. So this is unique because it doesn't happen with every patient, right? But if you do see this and you know there's a lot of movement that you want to achieve, CBCT is always best. So this is all the instance where CBCT is actually preferable. And you can take a picture, for all your cases. So you can go back to this and refer to this. But I don't expect you to have that picture in front of you every time you're going to submit a case, right? So just know, if we think that your cases tick any of these boxes, we are going to reach back to you and say, doctor, a CBCT is best in this case. So severe crowding. If you have severe crowding, there's going to be a lot of rotation, a lot of expansion, right? Maybe a lot of proclination. Maybe you're going to need extractions. CBCT is needed. We need to know the supporting structures of that patient. Orthodontic relapse, like I said, abyss on its own. This patient came, to a 3D Predict provider. It didn't look like much. It's actually moderate crowding, I would say, on the top, probably mild crowding on the bottom. And then the patient actually said, I had ortho a few years ago. That changed the treatment plan completely. Always ask your patients, have you had braces or aligners before? Because this was the initial presentation of the case. And that changes the treatment plan completely. It will do for me. So overexpansion is real. You just saw it from orthodontic journals I just showed you. Okay? Overexpansion is real, and sometimes those patients end up in your chair. So please always ask your patients if they have had ortho before. Expansion of more than 2 millimeters. This patient was expanded actually 4 and 3 on the lower. Usually CBCT is preferable because patients don't have unlimited amount of bone. The cortical plate is a cortical plate. So alveolar bone remodels, the cortical plate is a different situation with orthodontics, right? When you violate the cortical plate, you're going to have dehiscence and fenestrations. So please, if you suspect, right, that you're going to do a lot of expansion, if you see a completely triangular, right, upper arch, please submit a CBCT. By protrusion, if you're going to be protruding upper and lower, there's a reason why you're protruding upper and lower, right? That patient just doesn't have that amount of bone, probably doesn't have that amount of bone like you see here. It's better to submit a CBCT. Retraction of more than 1.5 millimeters, like in this case, same thing, anatomical boundaries. Bone exists to support teeth. We all know that. Bone goes away after you extract the tooth, right? So if this patient is not going to have a lot of lingual bone just waiting for you to position those teeth and correct overjet. Root torque, same thing. If you're going to be torquing those teeth, that seesaw effect is very easy to cause fenestrations. So CBCT is preferable. Gingival recession. You see, I talked about periodontal stable patients before, right? And I said it should not be within your first 15 cases. Obviously, for this provider, wasn't. There had to be a lot of follow-up with this patient to make sure that perio didn't reactivate. But this case was treated. It was treated with 3D Predict, and this is how it looked. But we were able to follow up where the bone, where the supporting structures were at every step of the treatment plan, and we didn't make the periodontal situation of the patient worse by the end. Implant site preparation, obviously, you want to have root parallelism. You want to make sure you don't know. You know how many cases I see that they made space for the crown and the roots look like they're going to kiss each other? And then where are you going to place your implant there? So it's the same situation, yes. So it's the same situation. We want to make sure we're making space for the implant and for the crown. Any complex case. Yeah, can we treat this? Absolutely. Severe open bite. We can treat it. This takes a lot of movement, probably outside of predictable limits. You're going to have some compromises periodontically speaking. So maybe this is going to be a case where you're going to have to talk to the periodontist, and it's going to have to be a dual case with them. But beyond that, I always suggest submit a CBCT, but it's always better to start with this, right? An open bite that is not that severe, but it's still challenging with aligners because the most challenging movement for aligners is actually extrusion, but not for 3D per egg. This case was completed within 1 year. No refinements, 2 millimeters of upper anterior extrusion, 1 millimeter of lower anterior extrusion. And you were done, and the patient is happy. Now, let's just focus a little bit of when CBCT is not needed, right? Once again, you can submit any case without CBCT, any case. You can't just tell patients you're gonna be taking CBCT left and right? No. But a lot of patients are not gonna accept that either. But if we see a case that really needs CBCT, we will let you know. Now, you can use what I mentioned before as a general guidance for yourself, but just know that any case that you submit, it will still be more predictable that even without CBCT, than anything else that is out there in the market. Because we have thousands of CBCT finished cases feeding our database, telling us the average width of the cortical plate, the average root morphology and anatomy for every tooth, how the supporting structures look, and how we can combine movements with each other until they become unpredictable. So what are the predictability limits? So submit cases. I don't want to scare you away from non-CBCT cases because we do non-CBCT cases. But please, if you have a class 3 patient, submit a CBCT with your case. I want to show you just some quick clinical cases that I think are great to start with, right? Within 1 year, and you're actually making a big difference in the life of the patient. We talk about deep bite. Look how deep this bite is. This is a 17-year-old. She has her whole life ahead of her. You're really just gonna have her on your chair and just let her walk away with that deep bite without having the conversation with the parent about what's gonna happen in 30 years, maybe less. I mean, this is a case that can be treated within 1 year. This actually took 9 months. 18 steps upper, 17 steps lower, no refinements, no additional appliances. And we got a good bit of intrusion, 1.5 in total between upper and lower. And it was only 4 visits. Remember I said 6, right? This was only 4 in 9 months. So it is profitable, it's the right thing to do by the patient, right? You're changing the quality of life of the patients forever. So it just makes sense in every case. And even though it doesn't look like in here it looks like quite a bit of movement, right? But in the upper it doesn't look like a lot. We did quite a bit. I mean, we were able to combine torque, rotation of canines of 19 degrees, which is very difficult. For those of you who have done aligner treatment before, you know how hard it is to rotate canines. 8 and 9, we rotated 15 degrees plus the torque, and then we did expansion of 2 millimeters upper and 1 millimeter lower. So it was quite a bit. And this was a non-CBCT case. I want to make it clear. Non-CBCT. We didn't reach out to the doctor and said, we need CBCT in this case because we felt that the movements were within all anatomical limits because we know, based on our database, and because this patient was 17, she didn't have ortho relapse. She never had ortho before. So this is a case that we did use CBCT, and it's a very interesting case because it has a supernumerary upper canine. Normally, if I would see this type of case, right, just, some crowding, nothing severe, right? Obviously, some intrusion that needs to happen on those centrals. I would say this case doesn't have a CBCT. But the minute the doctor said, oh, there's a supernumerary canine on upper, we said, oh, no, doctor, we need a CBCT. Because even though the movements that we may be creating on those upper anterior may not look like much, we may be bumping into that root. And in that case, then you may be looking at refinements, you may be looking at movements just not happening, right? So this case was actually 10 months. And you can see here the supernumerary, right? And just keep in mind, right, that The nice thing about our system too is that we have a lot of professionals behind it. It's not just a software that runs your treatments and gives you an ideal treatment plan or a set treatment plan. We took this case and we look at that supernumerary and we actually work around it. So we knew we could not do too much retraction because of that supernumerary, right? We knew exactly how much torque we could do because of that supernumerary, not to affect the situation because the patient obviously didn't want to have it removed. But I can't tell you what would have happened if we didn't have a CBCT or if any other company, even with a CBCT, they probably would not have care because they don't take into consideration the CBCT when they're treatment planning. They just tell you, doctor, it's bumping into the canine, what do you want to do? So that's the beauty of it too, because we take it into consideration. And this was the result for that patient. As you can see here, a lot of intrusion, torque intrusion of the lower incisor, 1.5 millimeters. Torque intrusion of those upper anterior, 1.5 millimeters too. So in total, 3 millimeters of intrusion upper and lower combined. And this was only 3 visits. Even with the supernumeraries, it was only 3 visits. So it was 1.5 millimeters of intrusion with no, just a plastic. Also, rotation of canines, again, 19 degrees. Expansion, 1 millimeter upper, 2 millimeters lower. Retraction, because we did retract 1 millimeter, but we didn't control because we knew where that supernumerary was. So we didn't go overboard. And the last case I want to show you, and this is just my last slide, is how you can integrate this into your practice, right? You see this case with severe diastemas, right? Walk into your office and the patient said, I hate these diastemas and I want to fix the situation. I want my aesthetics to be back to what they were when I was young or even better. How can we do this? And you think about, well, doing 2 huge crowns here is not the best situation, right? So what am I gonna do here? And you start thinking, well, maybe some ortho, and maybe I'm gonna have to refer. You don't have to do that anymore. This was not only fixed with aligners. This is an adjunct treatment, like I said. So we closed the diastema as much as possible because the patient had wear facets. The doctor was able to do the crowns after, crowns that make sense proportionally with the teeth of the patient. So, and this was done in 11 months and 4 visits. But this is how you can integrate this into your practice and actually stand up from everybody else around you because nobody else is offering this to their patients, especially within this amount of time and with these results. So that concludes my presentation. I hope you found it helpful and that you got some tips for your practice, and I answered some questions. But by all means, ask me any questions right now or later on, or set up an appointment with me if you have a clinical case that you want to discuss, right? At any point, we're here for you. You'll have the technician that set up your case in the call, and you'll have me to answer any questions and to walk you through every step of the treatment plan. So thank you very much. Any questions at this point?